So this is my title presentation, my
Producindo
worst
forma
peripheral arterial
periférico.
nightmare and how I solved it. I have no conflicts of interest. So the patient is a 51-year-old woman with a wound at an old left leg TMA site and also has rest pain. Her past medical history is listed here, all things consistent with a younger person with advanced PAD. Her TMA in 2014 was for osteomyelitis. Non-invasive studies showed moderate to severe distal disease. Her ABIs were not obtained due to vessels being non-compressible. This is her angiogram that shows patent aorta and patent iliac vessels. This is a angiogram also that shows patent common femoral, deep femoral, superficial femoral arteries. You see here she has a pretty focal, moderate severe stenosis at the above knee popliteal artery, and a little bit of a smallish vasculature overall here, but nothing terrible. Has flow in the anterior tibial artery down to the foot, has the tibio-perineal trunk that has some disease distally. You see here that the anterior tibial artery is the main rough to the foot, the perineal is small, and the posterior tibial artery is occluded. And this is the flow into their TMA site, her foot. So the thought was to potentially intervene on that stenosis here. Although she doesn't have any significant disease as far as occlusions or large lesions, it was thought that increasing a little bit of her inflow may help with her rest pain that she's having down there and may help heal her wound. During attempts to cross this area here, the wire came back after crossing the lesion. During when catheters were being transferred. At this point, angiogram showed an occlusion. You can see the knee joint is here. I'm pointing with my arrows. The angiogram showed an occlusion right above that area where that short focal lesion was, and we did not. We had very poor flow distally after that. And you can see here a more delayed shot showed a dissection and really poor flow distally after that, the angiogram. This is actually my partner's case. At this point, I got called into the room to help with the procedure. And another angiogram shows just very delayed filling distal to this area and really no flow distally. Patient clearly had a dissection at this point, and the wire access, unfortunately, across the area was lost during transfer. We were unable to get our wire into the proper plane here despite multiple attempts. We had pretty severe poor flow distally. Patient acutely started complaining of severe pain in the right foot and started moving on the table and getting agitated. And we were unable to get across this. Further attempting, at one point we thought we got through and tried to balloon it. And at that point, we ended up not being through it and probably made it worse. So the question is, what do you do at that point? An assessment of the foot at that point, the foot was cooler. There are no signals down the foot at that point where there were before in the dorsalis pedis, so we've clearly made her worse by causing this dissection. And we're clearly, with our wire, not in the true plane. I put an ultrasound on the foot, use a hockey stick ultrasound, and so no flow in the dorsalis pedis artery in the foot right before the TMA. Though what I ended up doing was I attempted to access this vessel that had no flow in it, but was able to see with ultrasound that I was in the lumen of the vessel, and I was able to get a 035 wire up and was able to use a bare quick cross catheter to follow it. We were able to get through retrograde, and we were able to get through and do a body floss from the right common femoral artery to the left dorsalis pedis artery. In this way, we were not able to antegrade get the true lumen, but we were able to get in there posteriorly, distally, And fortunately, even though there was no flow in the dorsalis pedis artery, it hadn't clotted off, and we were still able to treat through here. So you can see here, we were able to treat and get through, and we stented the area in question earlier, the lesion area, and also the dissection plane. However, we had clot in the proximal anterior tibial artery. You see afterwards here, down distally, you see potentially a dissection also in the anterior tibial artery and clot, and also clot in the TP trunk. We knew the TP trunk didn't really go where significant, so we thought we would ignore that. And you see another shot here that shows after some finagling that there's really a narrowing of the anterior tibial artery here proximally, and there's still clot in the right in the below knee popliteal artery right above that there. We angiojetted out and got out the rest of the residual clot. There's still a little bit there. So we did another pass with the angiojet. We placed a 3 millimeter coronary stent, drug-eluting stent in the proximal anterior tibial artery, which showed restoration of flow through here. So this is a case where, the lesion was a very focal, moderate severe lesion. Maybe a judgment call about whether or not this would actually improve her flow in her foot. I think it was, in retrospect, worth trying, but that we created a much bigger problem here. And I think what we always tell our trainees, and I always tell my fellows, is don't lose the wire. Whatever you do, don't lose wire access, because this is why. Because you go on dissection plane and you can't get back in it. So we were able to stent the SFA pop more above the knee. We were able to stent the anterior tibial artery, and we were able to, you can see the more proximal area here. And this is how this looks further down. And then we get down to the foot, and now the area where we stuck, which I had no flow on the ultrasound, still has no flow on it down here. So we took the smaller 014 angiojet and got out to distal anterior tibial artery, got all the way down to the foot there. And you see our wire is in the normal vessel there. We had removed our dorsalis pedis catheter. You can see here a little bit of extravasation from our access, but nothing significant, nothing bleeding on the outside. And we restored inline flow to her foot. Her wrist pain resolved and her wound was able to heal. But this was a clear case of what looked like a very simple chip shot endovascular lesion that we made a real potentially made a real mess out of, but we were able to salvage. And in my mind, my worst peripheral nightmare is a case that looks like an easy case to do, that you almost get yourself an acute limb ischemia and the patient going to lose their leg. And fortunately, we got lucky and we were able to